Good morning. This is like coming home. This is it's really fun to be here, and it's given me an opportunity. I've been away from the diving organization for about 6 or so years, but still seeing a lot of divers and doing a fair amount of surgery on them. And so it gave me the opportunity to put together my thoughts about what's gone on in the last 31 years or so with me with diving. So this is the official title of my talk, Prevention of Shoulder Injuries in Junior Divers, but really it's, is there a joint with a higher DD? Because I think the shoulder is a really complex joint that is somewhat difficult on a lot of levels. So background-wise, I've been doing this for 31 years. I've had a special interest in diving mechanics and injuries, and I've had some remarkable injuries. Part of my practice when I started out was going to the pool with Ron O'Brien and watching Olympians practice. And I would do that for 3 or 4 hours at a time, and I'd be at the underwater window watching what was going on in the water. And I could actually call that work. I got to sit with somebody who became one of my closest friends and learn. So, and divers were kind enough to teach me because that was my deal. They knew how ignorant I was about the sport. And my deal was I would take care of them if they would teach me, and I was just not the brightest guy in the world, but certainly smart enough to listen. So I got to learn a lot from divers, and I've always thanked them for allowing me to learn from them and allowing me to develop my craft with them. Understand that this is one man's opinion, and with the biases that come along with that. It's based on medical literature, a lot of which was written by Steve Anderson and myself. But also my experience, the experience of just a remarkable sports medicine staff that we put together over the years, including Steve Anderson, Terry Robinson, Bob Mangini, Dennis Fredette, Paula Alley, and people that some of you may know, some of you may not. So I warned you that this was my trip down memory lane over the last 31 years, so you could have lived through it because I got invited to be up here. I recognize that there are a lot of ways to train. I've asked a couple of people what their thoughts were about what's going on now. I have a lot of respect for other points of view. I don't think I have all the answers, and I welcome your thoughts and feedback at any point. I realize that we all have a different level of knowledge, and I don't want to be too basic, but I want to make sure that we all have some basic information for this discussion. So with that as a background, my plan for today is to go through the pathomechanics of how injuries occur in general, the factors affecting injuries in divers, talk a little bit about shoulder anatomy and function, shoulder dysfunction and injuries, relate that to diving, and then talk about rehabilitation from injuries, prehabilitation to try to avoid injuries, and then I'll reflect a little bit, and that you're going to have to go through that part again too. Well, patients come to see us either because they're having pain or they have dysfunction. And in order to have pain or dysfunction, there has to be some level of tissue failure. And tissues can fail in one of two ways, either a macro trauma, which is a single load or force, like a shoulder dislocation, which you see here. And in these cases, the cause and the consequence is very clear. In a diver's case, they hit the water wrong, or they saved improperly, the shoulder came out, you know what the cause was, and you know what the consequence is. Well, microtrauma, when the overuse injury is a little bit different. There's a repetitive cumulative force that eventually exceeds the physiologic tolerance of the body. And here, the cause and the consequence is much more complex and much more difficult to figure out. What we see as a patient who presents to us is the consequence. It's a result of inflamed receptors in the symptomatic tissue. The cause is usually a deviation from normal mechanics, especially in the overuse injuries. If we make the correct diagnosis and we're not just treating the symptoms, then we should be able to get the patient over the problem and we don't have the recurrence of injuries, especially around the shoulder, which I've been seeing over the years. But when we look at the pathomechanics of injuries, there are extrinsic factors and there are intrinsic factors. The extrinsic factors are the things that don't relate specifically to the individual. So in diving, that's the training regimen, the coaching, the facilities and environment, the equipment, what they have available for dry land, do they use a bubble machine, the pool, and more recently, the competition schedule has had more and more of an effect. Intrinsically, we look at the diver's flexibility, strength, power, agility, joint motion, stability, their nutritional status, maturational status, their skill set, spatial orientation, and then the psychosocial issues, which I think are becoming more and more involved with treating athletes now. When you think about the phases of the dive, and this is something you guys know a whole lot more than I do, when you watch this short video of Greg, I told you you were in. Think about the arm position, because we're thinking specifically of shoulder now. So we look at function as closed chain or open chain. Open chain means there's no resistance, the arm is free, when we're relating to the arm. Closed chain means there's some resistance to it. Okay, so obviously with the approach, the arms are free. In the press and flight, it's free. And when you hit the water, now you're going to get a little bit more resistance to the shoulder. Okay, and with the save, you're putting the arm in, depending on the mechanism of the save and the type of dive, more and more stress either on the shoulder or the back. Well, so most of the injuries that we see occur during the injury. Well, for most orthopedic surgeons, this is full range of motion in the shoulder, and that's adequate in every single sport except for maybe gymnastics, and definitely not in the case of diving, because when a diver hits the water, that's what they've got to do. Where's the motion? The motion is not happening at the ball and socket joint. The motion here is very clearly happening at the shoulder blade. And this may be new for some of you, it may not be, it may be redundant for some of you, but the focus of this almost hour is going to be shoulder blade. Okay, so what happens when the diver hits the water? Well, what happens on X-ray? Here's the shoulders overhead in the grab position. Here's the shoulders in the reach position, and all of the motion is happening at the clavicle, of the collarbone, and the scapula. That's the key. It's not the ball and socket joint. What we're operating on is the ball and socket joint, but that's the consequence. That's not the cause. Divers hit the water from 1 meter at about 19 miles an hour from the platform. They're over 35 miles an hour. The force at impact is almost 2.5 Gs. The diver is completely submerged within 140 milliseconds. And during that 140 milliseconds, there's a 53% decrease in the velocity with which they hit the water. Those are the numbers that go with entry. And they got to do it all without a splash. Not much of a challenge there. So with entry, we have the highest incidence of injury, the higher incidence of injury with backs and gainers, higher incidence on 10 meter than 3 meter, and this has not changed over the last 30 years. More injuries occur in practice than in meets. Well, that makes sense. You do more dives during practice than in meets. And acute injuries that we see are frequently associated with swimming and entry with the arms in a compromised position. What's absolutely remarkable to me as I reflected on this is Ronald Bryan and I figured this out in the early 80s. And divers are still doing their saves the same way. And they're still swimming entries the same way, and we're still seeing injuries related to the way that they're swimming their entries. Saving puts more stress on the low back and the shoulders, depending on the mechanism of the save, whether you're saving the back or gainer. And thinking, Ken Ferguson dislocated his shoulder on a dive that got 8.5s and 9s at the Olympic trials in 1988. Saving it. Looked like a great dive. Unfortunately, his shoulder came out. So now let's talk a little bit about the shoulder specifically. It's a very complex joint. There's the ball and socket joint, which we refer to as the glenohumeral joint, which is here. The scapulothoracic joint, where the shoulder blade attaches to the chest. Sternoclavicular is over here near the sternum, and the acromioclavicular joint is at the end of the collarbone. I apologize for some of these slides, but this is what we concentrate on. It's the ball and socket joint. Look how much bigger the ball is than the socket. And just for anatomy, there's a labrum, which you're hearing about a lot, but you might as well see one. The labrum is a little bumper that deepens the socket. It actually deepens the socket by about 50%. And then at the top of the labrum is where the top of the labrum is the biceps attachment. And that's the slat lesion that you hear about, the superior labrum, anterior, posterior, front and back. So you hear the terms, and now you can start, and you'll see a couple of pictures about what's involved with that. You hear about the rotator cuff muscles. The purpose of the rotator cuff muscles, there are 4 of them, is to put the ball in the middle of the socket and keep it there no matter where the socket goes. It fine-tunes the position of the head, or humeral head, and allows the ball to be compressed in the socket. More importantly are the bigger muscles. I mean, God's pretty smart. He gave you bigger muscles to do the more important things. So as humans, we have big butts because we walk. Upright animals don't have big butts. Animals that aren't upright don't have big butts. So obviously the muscles that are bigger have more significance in gross movements than small muscles. So the rotator cuff muscles aren't as important as the muscles around the shoulder blade. So when you have your divers take their rubber tubing and do their rotator cuff exercises, 3 sets of 10, I want to get up on the board, it's not doing a whole lot. So if you think about, and here are the names of the muscles, not particularly important, but the point is, it positions the socket. The socket is a part of the shoulder blade. So wherever the shoulder blade goes is where the ball is going. I'm going to talk about that in a little bit here. So the analogy that we always get is that you saw that big, when I showed the anatomical dissection, there's the big ball on the little socket, like a golf ball sitting on a tee, and instability is when you chip off the edge of the tee. Well, that makes sense if nothing's moving. The problem is the shoulder moves. So it's more like a sea lion balancing the ball on his nose. And by the way, it's sea lions, not seals, that balance the balls on their nose in the forest. So what happens there? So as the sea lion is balancing the ball on his nose, and this should be moving, there's coordinated motion between the shoulder blade and the humeral head, the ball, which allows the rotator cuff to compress the ball and keep it in the socket. So this is all not about the ball, it's all about the socket. And so when we look at some electromagnetic tracking studies, this is actually what happens. Watch what happens with the shoulder blade as the arm swings up. It swings out, it tilts back, and it goes over. Okay? That's the reality of the motion of the shoulder. This is from biomechanical tracking studies that were done. So with a diver, watch his right shoulder blade. This is the kid with shoulder instability. Okay, as he grabs and locks out, it's asymmetric. Look at the difference. It's his right shoulder that's involved, and then it just sort of jumps as he comes down. So as orthopedists, we tend to look from the front. We don't look from the back. Divers in the 80s made me start looking at it in the back, so now people in the country think I'm a scapula expert. But there's a big difference in the mechanics of that shoulder from that. Well, what do you have to do to get the shoulder up overhead, and what's the advantage of doing it? If you do it, you decrease, you hear about impingement all the time. If you get the shoulder blade rocked back, then you clear the space for the rotator cuff and the bursa. So if I ask this therapist of ours to bring his arm up just by lifting his chest, if he lifts his chest, his arm comes up higher. But he still can't get it all the way up. So I asked him, bring your arm up as high as you possibly can. And that's what he did. And that looks great. Except his alignment is all screwed up because his chin dropped and he went in and he arched his back. So if you have somebody with some limitation of motion in their shoulder, it makes sense that they may just very well hurt their back, especially on injuries. And one of the early studies that we did in Mission Viejo in the early 80s is we looked at shoulder injuries. And we were trying to find out all the different injuries that divers were having. And nobody that had a shoulder injury had a back injury. And nobody that had a back injury had a shoulder injury because they were using the opposite part of the body to save the dives. But as we followed them, the kids with shoulder problems had back problems, the kids with back problems developed shoulder problems. So all of this starts on the board. And Ronnie taught me years ago that everything that happens on the board eventually is what leads you to the entry. I mean, there are things you can do in the air to save that, especially if you're particularly talented. But if you're sitting back on the board, you've got problems. So when you press the board, what happens if you've got weakness around your hips? Because that's going to ultimately affect the shoulder. So this happens to be a pitcher. He throws the ball 94 miles an hour. He's a professional ball player. But watch what happens when I have him stand on one leg and do a squat. How he wobbles to come down. Look at his shoulder. So here's a thrower who's throwing the ball 94 miles an hour. When he gets up on one leg, drops down, all because of a problem with the hip. Well, what about this being your hurdle leg? And how much can you push off if you've got weakness around your hip? So we want to look at the shoulder in the context of the rest of the body, or what's called the connective chain. We see a lot of hip tightness in divers because of all the piking they do. If you've got a tight iliopsoas, which is the main hip flexor, that in your quads, then your lats have to be tight. If your lats are tight, that connects to your arm, and that has to put your shoulder in a malposition. So the point here is not to learn the names of the muscles or what exactly they do, but it's all connected.